better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the untethered way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Welcome to No One Told Me, the Airway Health Connection podcast. I'm Dr. Liz Turner. I'm going to walk you through cardiovascular disease and sleep apnea today, because it hits near and dear to my heart. So just yesterday, my dad had an aorta replacement. Yeah, that's a thing. So I'm very close with my parents. They're my best friends. They really are. I value them, and I value the fact that someone would make a decision to want to stay around. And so let's go into that a little bit. Back in January of this year, there was the opportunity to run a cardiac scan for less than normal. They're normally $350 or so, but a local hospital every year, I don't know if it's Heart Month or why they do it, but they run a scan for $100. And for the last couple of years, my parents were like, oh, we'll do it. Nah, we ran out of time. Nah, we'll do it. Oh, we ran out of time. Well, this year they did it. And what was discovered on my dad's scan was a 4.3 centimeter aortic aneurysm. And what an aneurysm is it's a thinning of the vessel wall. Think of it like a hose, like your garden hose. You have pressure coming through that hose. And if there's a bulge in that hose, eventually that area gets thinner and thinner and thinner until it explodes. And so think of what that does with the largest vessel in your body. The aorta, it ascends and then descends, and it goes over this arch. There are 3 vessels that come off of it. It's an incredibly important vessel, and you can't live without it. So what did we do? Well, it's his decision what he wants to do, but the hard part is, what do the numbers say? So at 4.3, 4.5, whatever it was, they're like, yeah, we don't really do it. But when you're 4.6, we do. So I don't remember the exact numbers, but we did a repeat scan here over the last couple months, and it had grown. And when you have a weakness in a tube that's getting bigger, you know eventually that tube that's under stress will let go. So my dad made the decision to have elective cardiac open heart surgery. And what does that mean? Well, in a lot of people, that aneurysm, it dissects, it separates. And in the majority of cases, the mortality, the risk of death, is very, very high. To go through elective, we have much more control. But at the same time, whenever they split open your chest down the middle, open up 2 sides, remove all the blood from your body, cool your system, cool your brain, and perfuse you so there's no tissue necrosis, brain damage, you run the risk of things happening. It's a dangerous procedure. Took 6.5 hours, and we're lucky. My mom's background is in cardiac surgery in the sense that she administrated or managed many open heart surgeons and started open heart surgery program. So we had almost too much knowledge, but also great knowledge going into this procedure. And that's one thing my dad said. He said, it'd be one thing if I didn't know anything, but I know too much. I know what pressure effusion on your brain is. I know what cardiac bypass is. And I know the risks that come from that. And when you got a guy who's feeling pretty good, who elects to go through that procedure, you ask yourself, how did we get here? So to go through and make that decision requires a will to live. And I think that's one of the coolest things I've seen in him over the last few years is more of a zest for life. And part of that is, I think, and his partner of 40 years in his ophthalmology practice, who sat in the waiting room with us for 6.5 hours yesterday, said it too, was him going on CPAP. So my dad grew up in a home where a lot of homemade food, like not a lot of processed stuff, has decent dental development in the sense that never had premolars taken out, but had wisdom teeth taken out. But he was always the guy that snored. He was always the guy that you could hear him from the room over. He would fall asleep flossing his teeth. He was kind of agitated. And part of that is a stressful life, right? He's a doctor, he's a surgeon. He's got a high stress job. His wife has a high stress job, my mom. We have 2 kids, managing all the things that go along with that, running a private practice. But at the same time, when you're not sleeping well, everything can go into a tailspin. So I start my airway journey, and if you've listened to some other episodes of this podcast, my background is I was a general restorative dentist for 8 years before I uncovered what I think, and the literature points to, breathing related sleep disorders being a huge risk factor for other chronic disease. And once you see it, you just can't unsee it. And that's why we're here, because the number of times in a day that my partner and my associates hear, "No one told me. Why didn't anyone tell me?" is outstanding. Because if we can look at preventive measures that have a trickle down effect on chronic disease, who wouldn't take that, right? So my background, general restorative dentist for 8 years. My son's born with oral ties. We treat that. A few days later, my father-in-law has a heart attack due to AFib. He threw a clot and years of undiagnosed sleep apnea. And back to the whole like dentist versus doctor thing. Like, sure, I'm not a doctor, but when it came to my father-in-law even, I knew enough about cardiac numbers after being surrounded by cardiac people my whole life, and it's not hard to Google it either, that at some point something would happen because his numbers weren't great when it came to coagulation. So he threw a clot, and that started kind of my airway journey. I thought to myself, what have we missed here? What did we miss? So then I started asking questions about my husband. He's got sleep apnea. Everybody just prescribed him trazodone. And then I look at my dad and I go, "You have sleep apnea." And he goes, "I probably do." And so he has a sleep test, and what are the numbers? So what is an AHI, apnea hypopnea index? It's basically a measure of the severity of the obstructive apnea. And there's no real science behind mild, moderate, severe. But the numbers are mild. A lot of times they'll tell you no treatment indicated. Moderate, you qualify for an oral appliance or CPAP. Severe, you're CPAP, and when you fail that, you can try an oral appliance. But at the same time, when you look at what that number actually is, it's not just mild, moderate, severe. It's how much oxygenation you're missing in the night. So AHI, a number of 1, is 11 seconds. So it's the number of times you stop breathing per hour for 11 seconds or longer. And when you look at these numbers and you try to do this yourself, you say, that's a lot of time without air. So go ahead, let's hold our breaths for 11 seconds. Was that hard for anybody? It was hard for me. And when we look at what my dad's number was, it was 63. He stopped breathing 63 times per hour for 11 seconds or more. And most of those apneas were upwards of 25 seconds. So the average apnea was 28 to 30, if I remember correctly. So to think about holding your breath for 30 seconds, once a minute, for an hour, that means half the time that you're asleep, you're not breathing. And what does that do to our system long term? Apnea is a progressive disease. He wasn't born with apnea. But he was born, like a lot of us, with a low tongue posture, slightly underdeveloped jaws in the sense couldn't support wisdom teeth. And I will attach some images to this, but he has what we call an edge-to-edge occlusion, where his lower teeth have kind of migrated into the upper teeth and flattened them. He wants to maintain the patency of his airway by the lower jaw coming forward. He has a restricted envelope of function. And instead of having TMJ pain and creating an open mouth posture, he more shifted everything forward, and he's flattened his front teeth and kind of reversed his smile line. So for general dentists listening to this, this is the type of stuff we go into in our course. So the Untethered Way foundations, that's where we talk about occlusion and where and how that relates to apnea, because at the end of the day, the upper jaw, the maxilla, the hat didn't fit on top of the head, the mandible, the maxilla was too small. And so he compensated and he adapted, but that disease progressed. So over time, we see clenching, we see grinding, we see development of tori, buccal exostoses, further taking up more room within the oral cavity, further worsening the obstruction. And then we throw in alcohol, we throw in high cortisol levels, we throw in inability to lose weight and being overweight for 25 years. So no, he wasn't born with apnea, but the progression of the disease increased in severity, likely exponentially over time. We don't have a sleep test from 15 years ago, 25 years ago, like we do on some patients, but we got one from 7 ago. So what happened? So he's got severe sleep apnea. He gets a CPAP. And in conversation the other day, we were talking about some things and airway health, airway dentistry. He's lost 40 pounds. And like a lot of people who had difficulties losing weight and maintaining, a GLP-1 came into play. And that is a treatment for obstructive sleep apnea because he dropped 40 pounds. And that man was running 6 to 10 miles a day at 230 pounds and putting this system that is under stress and pressure at night through stress and pressure during the day. So that was part of the decision to do the procedure. The surgeon said, you know what, Stu, if you were 40 pounds heavier, we wouldn't do this, or we would do it. But the weight you are, like, it's okay. We can push it off. We can monitor. We can watchfully wait. And I go, well, did you mention that you lost that weight on Ozempic just 4 months ago? Like, come on, you guys, look at the big picture. That system is still under strain. So he's got a CPAP, and he became a different guy, like the shorter temper. I mean, still there. We're still the people we are. His ability to converse, to be social. If you know my dad, it's never going to be chatty Cathy. But when you get him going on a subject he wants to talk to, he can sit there and enjoy a conversation with you versus wanting to shut it off immediately. So now that he did actually have a repeat sleep study in the last few weeks, and his apnea has gone from severe to moderate. And it's not gone. It'll never be gone because the development and the impact on the brain and the body has happened. So we have a long draping soft palate from years of mouth breathing, and then couple that with the positive pressure of the CPAP. What I'm trying to get at, though, is that when we look at statistics and we think about everybody as a whole, you say, okay, your risk of developing cardiovascular disease is 1 in 10. Like, maybe I won't be that one. But when you are, or a member of your family is, it's hard to stomach that you could lose them, or that they could have to go through something and recover from something that could kill them. And to get on the other side, it takes work and effort and time, and it takes healing, and it takes recovery. So why don't we do more to prevent? Because let's talk about what sleep apnea and underdevelopment of the jaw is, the relationship between those. And let's also talk about sleep apnea and cardiac disease. So when we start to think about apnea and cardiac disease, what happens during sleep when we stop breathing? Our oxygen levels drop. We desaturate. So Stu, my dad, was desaturating into the 80s. And Even now with the CPAP he has, he knows that he doesn't desaturate, he's oxygenating. And that continuous positive airway pressure, CPAP, is keeping him alive. It's keeping him breathing. CPAP save lives 100% of the time. There are risks with them, and compliance is low. But in the conversation with my dad, he says, you know what? I'm attached to my CPAP. I love my CPAP. I've become accustomed to it. And even if I could get off of it, I don't think that I would want to. If given a choice, I would stay with what I'm doing. And at 71 years old, when your body has been in fight or flight distress mode for 30 years, that blanket, he said it felt like a blanket, that blanket that the CPAP provides gives him this sense of security that he's going to rest, that his body can calm down. So no, I wouldn't put him in oral appliance. I wouldn't talk about orthognathic surgery. This is where he wants to be. We're going to have to rehabilitate his teeth at some point. And at that point may come a conversation about orthodontics, troyer removal. What else can we do to optimize your airway size? We can do some soft palate tightening on him to tone down the laxity of that soft tissue in the back of the throat. So there's a lot of things we can manage to help make his CPAP more effective with less pressure. So but what happens when we stop breathing? Our oxygen levels drop. Our brain, our body isn't perfusing as well as it should. And after I believe it's 4 minutes without oxygen, there's permanent brain damage. 60 minutes with half of that not oxygenated, that's 30 minutes without oxygen with some breaks, so no brain damage, but systemic inflammation and damage can occur. So the brain panics. It sends this stress signal, the heart rate spikes, and that's what we'll see in these sleep tests, is this increase in the heart rate. The blood pressure goes up. The body has a ton of adrenaline released. And so imagine that happening, for example, 60 times an hour in 7 hours of sleep. Imagine that happening 20 times an hour, 10 times an hour. It's not good no matter what the number is. It's still damaging. So over time, this repeated cycle of oxygen deprivation and stress activation, it leads to hypertension, arrhythmias, stroke risk, even heart failure because of the pressure that organ is going through. And in some people, higher risk of aneurysm, right? So that pressure on that tube, that pause, that flow, that pause, that flow, we see these increases in the heart rate. We don't see a consistent pattern. That organ is under immense stress. And lucky for him, he'd been managed with lipid management. So cholesterol and blood pressure had been managed with medication for years, but the structures were damaged. And so when we look at what the American Heart Association says, it says that untreated sleep apnea, it doubles the risk of heart disease. And that's often left out of the conversation is why people have sleep apnea. Why does it develop? And so, like I said, it's a progressive disease. There are people born with sleep apnea. And for whatever reason, structural obstruction, we can have central sleep apnea. There can be so many different reasons why someone's born with it. But let's for today's purposes talk about how it progresses. So when we think about the cycle of dysfunction with breathing, when we're born, we should be nasal breathers. Nasal breathing is healthy breathing, no matter what way we look at it. It's healthy breathing. It warms, it humidifies, it detoxifies the air, and it allows for nitric oxide release, which is the oxygen carrying molecule in our blood, to be optimized. So we have more oxygen and perfusion going to our vessels because we have better oxygen carrying. There's decreased turbulence of the air, so there's less collapsibility of the airways with nasal breathing. So babies should be obligate nasal breathing. And if you look at pictures today, you see a lot of kiddos out there who aren't nasal breathing. And we think it's so cute. And we think, oh, they're so adorable. And they're laying there with their little mouths open. And you see these newborn pictures and the mouths just hanging open, the tongue's hanging out. And now I think to myself, that's not cute. That's the first sign of dysfunction. Because that mouth breathing, it can persist. It can lead to less clearing and cleaning of the air, more irritation of the posterior pharynx, more risk of developing acid reflux, silent or known, which leads to even more irritation of the tissues in the back of the throat and nasal cavity. We call those the tonsils and the adenoids. And there's a big argument. Mouth breathing doesn't cause tonsil and adenoid hypertrophy. I would argue the down trickle of mouth breathing causes tonsil and adenoid hypertrophy. If we have a continued pattern of reflex or aspiration into the nasal cavity, how can that tissue, that lymphatic tissue, not become aggravated by the continued acidic irritant? So no, mouth breathing may not directly cause tonsil and adenoid hypertrophy. And there's a really well-known, amazing, prominent ENT who argues this all the time, that it doesn't cause it. But again, the downstream effects of mouth breathing can absolutely lead to hypertrophy of tonsil and adenoids in the environment they're in, because we also have to look at the structure. So the mouth breathing persists, the growth changes. Mouth breathing can, and then couple it with tonsil and adenoid hypertrophy, so enlargement of those. We have to learn to breathe around them. And as humans, we will adapt. We will do our best to work hard to breathe around those tissues. And so we'll posture our jaw forward to breathe around our tonsils. We'll open our mouth to breathe around our obstructed nasal cavity. And that can alter our growth profile. It can lead to the two jaws, the upper and the lower, the maxilla and the mandible, not being as harmonious as they could be. Because argue whatever you want. Is it the maxilla's problem? Is it the mandible's problem? It's both jaws' problem. Because if they're not in harmony, something happens. Either the jaw sits back and causes TMD, temporomandibular dysfunction and pain, especially in females. Or maybe it postures forward and we see that wear on the front teeth like we do on my dad's. We then lose some vertical dimension. We clench our teeth. We create bony exostoses or little tori, little bony bumps that take up more room in the mouth. That mouth breathing, it then becomes snoring. Snoring isn't a diagnosis of sleep apnea. It's not sleep apnea, but it's a red flag that it could be there or coming. Because then that's snoring, and maybe it's because of resistance in the nasal cavity. Or maybe it's because the posterior pharynx behind the tongue is too small. Or maybe it's both. So maybe that snoring becomes more of an upper airway resistance. Like we're creating pressure on a teeny tiny straw as we breathe through our nose. So take a deep breath through your nose right now. And then take one through your mouth. I ask kids that all the time. What do you prefer? There's no wrong answers in my office. I want to know if you like breathing through your nose or your mouth better. You like breathing through your nose or your mouth, there's no wrong answers. And I say it really fast like that because it doesn't give them a second to think that there could be a right answer. And then they go and they do both. And most of the time, they will say, my mouth, for sure. In some cases where parents have been working on this, I can hear the resistance in the nasal cavity, but the kid knows what the parent wants the answer to be. And they'll say, my nose. And then they go back to sitting watching Netflix with their little mouth open. So that upper airway resistance, it decreases our ability to flow that air passively and well. So that snoring, it progresses to nasal resistance, which what does that nasal resistance do? It causes collapsibility down behind the tongue, and that's obstruction. So that upper airway resistance, still not a diagnosis of sleep apnea. If we think about the numbers, we have so many people come and say, you know what, they said I don't have sleep apnea because I don't desaturate, I don't stop breathing for long enough. But there's disruptions in the quality of the breathing, and that's what we should be looking at. We can't put everybody in a box and say you're mild, moderate, severe, because that collapsibility of the airway after that resistance develops or worsens becomes obstruction. And what does obstruction do? Well, our body, it tries to protect ourselves. How many, for you dentists listening, how many of your patients have said, you know what? I ground my teeth, and then I retired and my stress got lower and I stopped grinding. It's not stress. It's the fact that the body was protecting itself for a long time and then it stopped. Grinding your teeth is a sign that your body's trying to protect its airway. It's trying to stimulate saliva to buffer some acid. It's trying to stimulate the oral muscles to stay patent so we can breathe. And at some point, that body's under so much stress and pressure that it stops doing that. So we can see people who have had significant obstructive sleep apnea still be undiagnosed, still be medicated, still be on other cardiac meds, hypertension, hyperlipids, but nobody's looked at what else could be contributing to the reason we even need these in the first place. So the structures matter because the structures are part of the patency or openness of the breathing tubes, and that starts in childhood. So we can modify growth. We'll never be perfect on paper. Nobody is. There's no such thing, in my opinion, as a perfect skeleton for all the third molars to fit that has full harmonious occlusion and has perfect midface development because we're genetically different. We are different from a race perspective. We're different from a mixing of races. We have all different histories and we have different genetic predispositions to certain shapes. But at the same time, we should be working to optimize the size of those structures to manage how we breathe. So let's look at how this structure and the sleep apnea continue to relate. When we think about what's told to people with severe apnea, they're told to lose weight, right? This isn't just a weight problem, or you're stressed and you can't lose weight, or you need to tone down on your diet. There's a huge link between sleep and cortisol. Inability, that stress hormone doesn't just come from being stressed from work, it comes from not sleeping. So in my dad's case, that's where the GLP-1 was so beneficial. I mean, you've got a man who's been with significant apnea, and I'm not going to use the term severe because I would consider whether he was on the spectrum of mild, moderate, or severe to be significant because it was all putting stress on the system. And that's why in my practice, I tell families, they say, is it mild? What is it? Is it severe? Is it a severe tongue tie? I say, I really don't like those terms. They're not great descriptors. They say it's symptomatic. The anatomy could be this, this, or this, but the symptoms are present, whether the anatomy is mild, moderate, or severe. So the significant apnea led to further inability to lose weight because of an increase in cortisol. So the GLP-1 helped manage a lot of the things, even self-medicating with alcohol to help with sleep. Because, we come from a family of alcoholics. My dad was raised by wonderful parents who did the best they could with the tools they had, but it was a pretty dysfunctional home. And if you look at what that does weighing on the psyche of a person, there's a great book that I'm obsessed with right now called Scattered Minds by Gabor Mate. And it talks about childhood and the implications on stress and attention and striving for perfection. And if you know my dad, that's what we are. Like, striving for perfection but can't complete a task. And the man, he finished 2 boats. He flipped over the camper that he'd built. He completed his 15th Windsor chair. He had a lot of projects he wanted to finish before he had this procedure, but he would start something and not finish it. And so toning down on the drive to eat, to snack late at night, to have the alcohol, to shut that off is a blessing. And so that's where I'm really thankful that these medications exist, because it was one more push in a lust for life. I think rediscovering life beyond excess alcohol and excessive eating, all of those things can make a person happier because you find joy in other stuff. So these underdevelopment of the jaw, it's an architecture issue. It's a structural issue. Whether they're narrow, they're set back, they're vertical, narrow, and set back. The tongue, it just doesn't have room to rest where it should, and that harmony of function is lost. The tongue itself, when we're overweight too, it's a muscle, but there's adipose tissue. So if we have a house that's too small, like a lot of our dental patients that have big necks, worn dentition, they've lost vertical space. They have an enlarged tongue because there's too much adipose. They also don't have the room for the tongue to live. So the obstruction worsens. So this is what's happening in the airway. That all of it's connected. The upper jaw, the lower jaw, the soft tissue, it's all important. And if we can't manage it, that's where we can start to see apnea or airway obstruction develop. So again, I keep alluding to like the small jaw problem, and why is it a big heart problem? Well, when this obstruction continues to worsen and worsen and worsen, and it happens night after night, this cardiovascular system, it never truly rests. So every apnea event it's a micro heart attack in a way. It puts stress on the system and causes that organ that has to perfuse and keep us going, it causes it to be under pressure that it doesn't need to be. This blood pressure increase, the vessels kind of stiffening, the heart working overtime to compensate for these oxygen drops. So what does that lead to? Increased risk of AFib. My father-in-law throws a clot, arrests in the doors of the emergency room. Right heart strain from pulmonary hypertension, chronic systemic inflammation, diabetes, insulin resistance, and metabolic dysfunction, and stress on the vessels, aortic aneurysms. So this is a vicious cycle, but we have factors that we can control. And whether it be CPAP or oral appliance or expansion or UPPP or whatever we want to do to manage the structures through air pressure, through propping the jaw open, through widening the jaw, through improving the dentistry and making more space for everything to be, we're doing something that's airway positive. Of course, I'm biased towards growth modification, right? I see a huge opportunity in growing kids to manage the soft tissue, improve on the tongue mechanics and posture and muscle strength, to help decrease the systemic inflammation, to widen the jaws, to improve the airflow, to refer to ENT, to talk about tonsil and adenoidectomy where it's indicated. We want to improve breathing. We're not just about tongue ties here. We're about whole body health, because that's the root of it. Improve on the structures, improve on the breathing, improve on the health system. So as a dentist, I can treat dental issues, and I love it because I can, as a side effect, have a positive, or if we don't do it in an expansive way, a negative effect on how someone's health is. So I think the best thing that I could tell everyone listening to this, whether you're a parent, a provider, medical, dental, lactation, chiropractor, ask the question of why when you've got a patient in your chair that's on hypertensive medication, high cholesterol medication, GLP-1, diabetes. Has anybody tested your sleep? Because we're talking end stage disease here, right? We're talking this will kill you. And even sitting in the hospital yesterday, surrounded by people that we care about, it's hard to not look at the system and say it's broken. The system is broken. Because here we are, and this is something the anesthesiologist said that really resonated with me. As someone who maintains a private practice and cares about the patient experience, he's sitting there and he's about to go into, well, Stu. He's from New York. He talks with his hands a lot like I do. I really, really like the way he communicates because he gets on the patient's level. And that's one thing I always strive to do, because the things that we're talking about are hard. No matter how big or small any procedure on yourself or your family member is challenging. Financially, stress, time, discomfort, all of it's hard. We're sitting here and he goes, Stu, I'm about to have a really big conversation with you about a really big day in your life. And I get emotional talking about it because they're about to take him back and cut him open and take out his blood, take out a big piece of his heart. And he says, but all around us, all we have is noise, because all you hear is other patients. All you hear are beeping machines. All you hear is laughter and nurses chatting, and no one thinking twice about a patient-centered approach, except that one anesthesiologist and the family sitting next to him. So we're talking end-stage disease where we're looking to keep someone alive. The patient behind that procedure almost doesn't matter, because if they're dead at the end, there we go. If they're still alive, they have a long recovery. But we did our job, we saved their life, right? But we don't really think about the patient that's sitting in the chair in front of us. And so that's where, as providers, we can ask better questions and we can be better focused on the patient in front of us and what got them to be with us in the first place. Because whether it's a question of the structure or the stress or the lifestyle, it's the patient that walked in the door, right? They came in to see you because they're asking for help beyond what anybody's offered them in the past. They may not be knowing that you can provide them alternatives, because if you're in a general practice and you're screening and you're reading their med list and you're taking their blood pressure and it's high, and you say, finally, have you had a sleep test? And they say, no, I don't sleep well though. No one's really asked me. You have an opportunity to say, you should get one, because it could save your life. Sleep apnea takes 10 years off of a life. And so that's my plug. It doesn't matter what you do, but do something for these people that you care about, because they're your patients, or at some point, they're members of your family. So we get through this procedure, right? And we sit there for 6 hours and we're waiting and we're waiting and we're waiting for calls. And still, hospital approach versus patient-centered. We're all in healthcare. Everybody's sitting there. My dad was lucky enough to have 3 of our best family friends. His partner of 40 years who said, I'll be there. I'll be there to see you go. My dad said it was immediate family only. That's what he was told. So he said, tell him you're my brother. So his brother, Fred, walks back and says, you got this. Both of them, man, a few words, both incredibly talented, artistic woodworkers. And there's a reason that they connected so well as medical partners. They're ophthalmologists, perfection and detail. And they're both woodworkers, very, very talented. Fred builds these things called rose engines. They're sold. There's only a few in the world, and he makes most of them as a hobby. And then you've got my dad, who loves to build furniture, really intricate furniture. And so his brother Fred goes to say goodbye. And the last minute, this other couple, our best family friends, we were just at one of their son's weddings. They walk in and I hear the nurses chatting. They go, I don't know, like his one brother's here, but now there's like another brother and like a sister or wife or something. And I go, oh, Mark and Patty are here. And so Mark and Patty are there. And Mark's he lectures all over the country on, he's a pharmacist and an MD, maintained a private practice for years. And so my mom and Patty are both hospital administrators and nurses, and my sister's a nurse and in medical sales. So all of us are familiar with healthcare. But again, I think it's so easy for us to look at the big picture and not at the person in front of us. And so I think in our practices, we could look at the big picture and not the person in front of us and say, oh, well, I did my best job on that tooth today, or I did what I could to treat their gum disease. But if we don't ask questions about their health too, we can be doing a disservice in keeping people as healthy as possible from a dental and a health perspective. And so we're sitting there and we're waiting and waiting for calls and check-ins. And luckily we had some ins on the inside and we were able to get some updates as we went along, but it wasn't really hospital policy to do so. I still feel that if I hadn't said you have sleep apnea, no physician, especially to another physician, really would have said, well, Stu, you need that sleep test. It would have had to come down to him asking for the sleep test, as he did. And it's our fault, right? Because as doctors, we can often say, I know what I'm doing. He should have been on a CPAP 20 years ago or managed in a different way years ago. But he wasn't, because we didn't know. And we didn't think about the long-term implications. We just think about sleep apnea as being tired. We don't think about all the other stuff that comes with it. So he's out of surgery. He's on the other side. I got to see him intubated and asleep before I had to hop back on a plane to come back to Denver to see my team for a big meeting that we had. But he's up and awake and ready for the next step of recovery. But, it's funny, the only thing he brought into the hospital was his CPAP. And it's the first thing he asked for, along with his glasses and his phone. He said, I need my CPAP. Because I think that fear of not being able to sleep well, and also the down trickle effect of what it's caused, will stick with him forever. So I hope any of you listening to this, if you've had a family member that you've been worried about, maybe this will give you a reason to speak up. Or if you've lost somebody to cardiac disease, maybe this will give you a reason to ask better questions for the patients that you treat. Because I know that so much of what I do and the way I treat is through personal experience. I mean, we've run the gamut of tongue ties to upper airway resistance, to jaw underdevelopment, to sleep apnea, to CPAP, to appliances. Like, there's no one right treatment, but treatment is something in itself because it helps the system be more harmonious. So I know that's kind of heavy, and I hope that we can keep doing what we're doing when we look at airway dentistry. It's hard to not get a little jaded in this space, in the sense that there's so much pushback on well, there's not a tongue tie and airway dentistry isn't a thing, it's a fad. But breathing's kind of a big deal, is what I think. It's not just airway dentistry is a fad. It's not that we're trying to make money on the term airway. It's that breathing's cool and it's essential for life. So help your patients breathe better is my takeaway from this. Help prevent bigger stuff as a down trickle. You can't save everybody and you can't prevent everything, but you can reduce the risk factors that are sitting right in front of you. This is No One Told Me, the Airway Health Connection podcast. I am Dr. Liz Turner. Like it, follow it, share it. Sign up for our course, Foundations, the Untethered Way. We have a new course coming out. It's a frenectomy surgical protocol. I got started in this space because of this little thing called a tongue tie, and it opened my eyes to all that I've been talking to you about today. Structure matters. It changes over time. Health and our ability to combat chronic disease, it changes over time. We have a lifespan that we want to be long and fruitful and full of quality. So let's do the best we can for all of our patients. Thank you.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
Want to learn more about Airway Health or connect with our team?
Please visit our website, untethererairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.